the key message for this particular top-end research that we were able to do with our collaborations with Tempus genomics platform is the fact that cholangiocarcinoma is a target-rich disease. And I cannot reiterate this more enough that it is indeed a rare, not necessarily rare, but underestimated to have how many genomic aberrations that are truly actionable. What we tried to focus on was actionable findings. And when I say actionable, we tried to outline and estimate the findings for which, A, there is a readily approved drug. So for example, FGFR fusion, for which you have pemigatinib approved, or B, if you had readily available trials. So for example, we have trials for BRAF inhibitors, trials for BRCA1/2, PALB2, some of these DNA repair aberrations, trials for MET as a target. Or if some things that are already endorsed in the guidelines. We saw at ASCO GI this year, we saw the updates from the IDH inhibitor trial, and it's already endorsed in the guidelines. So if I'm able to find trials or off-label therapies that have some promise, or even updated case reports where similar researchers were able to use a target therapy. So for example, for R5E1, which is an EGFR-sensitive aberration, we try to focus on just these aberrations to make it clinically more meaningful. And our finding was that in at least a third of the patients, which is not a small number, we were able to find these 8 actionable findings of interest, which further emphasizes why upfront genomic sequencing is important. The second main aspect that's unique to our research was this includes tissue as well as liquid biopsies combined. If there is one poster child where NGS often fails is cholangiocarcinoma, and often pancreas cancer fall victim to the same issue, is the fact that often the diagnosis is made on endoscopic ERCPs, where tissue is not even sufficient sometimes for diagnosis, let alone for next-gen sequencing. And we actually showed that liquid biopsies or circulating tumor DNA-based testing can fill that void, where we were able to compare and contrast the findings through the Tempus tissue as well as the Tempus liquid biopsy platform, where we were able to show that there were certain aberrations which were found more often in liquid, and certain that are seen pretty much equally in both platforms. Some of this is selection bias. Probably in some instances, liquid biopsy was sent because tissue wasn't necessarily available. But also we were able to show that we simplistically estimate that liquid biopsy is not necessarily useful for large genomic aberrations, i.e. fusions, but we were pleasantly surprised to notice that within our cohort of these actionable findings of interest, FGFR fusion, for example, was more often picked up on liquid biopsies. And now with pemigatinib already approved, and at ASCO GI this year, we saw another FGFR inhibitor showing similar efficacy. That's of value because for these subset of patients, advances are coming truly from a precision medicine standpoint. So while we are not able to necessarily improve outcomes for all cancers, but within these genomically subset, the only way you can improve their outcomes is to actually find them. Simplistically speaking, the lock has to be present for the key to work. Otherwise, how would you know which patient to prescribe the particular medication for? And that's what we were able to show, that both for liquid and tissue, liquid can fill the void. It's not the question of either or. The way I see it, it's an added tool, and especially more meaningful in situations where you have lack of tissue. And the ones where you were able to have target therapy prescribed, like any target therapy, it works really well initially, and then later on there are acquired mechanisms of resistance. For FGFR fusions, you have FGFR mutations. For IDH, you have the isotype citrine. And for a lot of these BRAF inhibitors and other aberrations too, downstream, down the line, they develop mechanisms of resistance. And again, because liquid biopsy is non-invasive, you could use it for longitudinal or serial monitoring. And we showed serial data on some patients who had this type of testing done.